It's Lexi Linden, and for my pediatric case study, I chose to talk about Rett syndrome, or RTT, is a rare and devastating neurodevelopmental disorder that impacts nearly every aspect of an individual's life, including their ability to speak, walk, eat, and even breathe. Rett syndrome is a genetic disorder that is caused by a spontaneous pathological variant or mutation in a gene called the MECP2 that is located on the X chromosome. This gene is important for brain development and for activating other gene functions. When the MECP2 gene does not function properly, it affects the whole body. These mutations usually cause spontaneously and are typically not inherited, making Rett a sporadic gene condition. They result from random changes in the genetic code that happen during the time of conception. Due to the X chromosome connection, this syndrome primarily affects girls. Currently, there is only one FDA-approved treatment specifically for RTT, available in the United States and Canada. Most care strategies focuses on symptom management through a comprehensive multidisciplinary approach to enhance the quality of life. There is currently no cure for Rett syndrome. Manifestations of Rett syndrome usually appear in several stages. Early onset occurs during 6 to 18 months of life and causes loss of purposeful hand movements, regression in language, and slowed head growth. The rapid destructive phase occurs during 18 to 36 months and includes loss of previously acquired skills, including walking, speaking, and hand movements. The plateau phase occurs between ages 3 and 10 and is a stabilization of symptoms, but patients still present with motor and cognitive impairments. In the last phase, occurring after age 10, is the late motor phase, which includes stiffness, loss of muscle tone, and difficulty breathing. Symptoms can begin as early as 6 months old when parents begin to see their child missing developmental milestones and lose abilities they have already gained. These symptoms include slowed growth and development, loss of purposeful hand function, involuntary and repetitive hand movements, loss of speech, loss of movement and coordination, distinctive eye and facial movements, seizures and epilepsy, breathing issues, gastrointestinal issues, scoliosis, and sleep disorders. Rett syndrome is not a degenerative disorder. Bearing illness or complications, individuals with Rett can live into adulthood and beyond, but require lifelong care. Rett syndrome is considered a clinical diagnosis. Diagnosis involves clinical evaluation by a doctor, genetic testing, and observing early developmental signs in infancy based on a list of diagnostic criteria created by Rett clinical experts. Early diagnosis is essential for the effective management and support. Unfortunately, individuals often receive incorrect or delayed diagnosis because in early stages of RTT, it shares many clinical symptoms with other neurological and developmental disorders like autism, cerebral palsy, and epilepsy. In contraindications for therapy, hygienists should consider cardinal features characteristic such as teeth grinding, altered breathing patterns like hyperventilation and breath holding, poor sleep patterns, feeding and gastrointestinal problems, occurrence of seizures, scoliosis, small feet and hands, failure to thrive, and the development of osteoporosis into their treatment. Therefore, contraindications include laying the patient in the supine position or DOE such as syncope. I want to announce that pictures and names used throughout this PowerPoint are not actual patients. My patient's name is Katie Moore. Katie is 5 years old and just began her second year of preschool at Sunbright Academy. She lives with her mother, father, and twin sister Lacey. She enjoys sticker activities, dancing to music, and all things purple. Katie's favorite snacks are bananas, confetti muffins, and applesauce. Katie's chief complaint was a recare appointment or checkup. She was last seen in my office 8 months ago. Due to other doctor's visits and everyday life occurrences, her appointment kept getting postponed. Katie is a patient of record at Johnson City Family Dentistry in Tennessee. Her dentist's name is Dr. Smiley. She is also under the care of a physician at Vanderbilt Rett Syndrome Clinic in Nashville, Tennessee. Her specialist's name is Dr. Nicely. Sometimes, but very mildly, Katie's gums bleed when she flosses. Her mom was educated on proper brushing and flossing techniques by an RDH. Katie brushes once daily and flosses twice weekly with help from her parents. Katie is more compliant with treatment with mom or dad present. Her last dental visit was in February of 2025, along with her last cleaning. Her last dental x-rays were in 2024. Katie was last seen by her physician in November of 2024 for her Rett management. She has now entered the plateau phase. She presents with diarrhea as a medication side effect. She has a delayed mental health. Her respiratory problems include holding cold breath. She has gastric reflux, which consults for her gastrointestinal issues. Her mom marked yes to having an eating disorder, but she is just a very picky eater. Katie's vitals today were within normal limits with a blood pressure of 128/82 taken on her right arm while she was sitting. Her respirations were 18 breaths per minute. Her pulse was 88 beats per minute, and her temperature is 98.2 degrees Fahrenheit. Katie is currently taking 2 medications. The first medicine she takes is called Dayblu. Triphenotide is a synthetic version of a naturally occurring molecule that is believed to reduce inflammation and support synaptic function in the central nervous system. She takes 5 milliliters once a day with breakfast. Dayblu's common side effects is diarrhea. The next medicine she takes is called Nexium. It is a protein pump inhibitor to lower the amount of acid the stomach makes. She mixes 1 packet a day with applesauce. The dental-related side effect of Nexium is xerostomia. Katie has entered the plateau phase where her condition has stabilized, so her parents are implementing every developmental assessment as possible. Katie's parents are established patients at my office, so I hope to impose many influential factors for each member of the family. Katie currently has a good physical status. Her dexterity and mobility have moderately increased. On the other hand, her mental status is delayed due to her disorder. Considering her condition, it is normal for her to be at this level. Upon my extraoral exam, I first noticed her cute glasses. Due to her loss of perception in response to visual stimuli, she is required to always wear the purple frames. Katie can walk, but her gait presented with a lack of coordination, leading to an unsteady walking pattern. Denoted by her square-angled facial appearance, I also noted masseter hypertrophy. Other than the enlarged masseter muscles, her TMJ articulation felt normal. Intraorally, I discovered signs of bruxism, such as Ware facets. I also noted a high palatal arch in trauma to the soft tissue that indicated finger sucking. Katie's mom confirmed the thumb sucking and also notified that Katie is a mouth breather. Her tongue appeared coated, giving rise to mild halitosis. Katie's mom had also shared that she has issues with bedwetting. Due to Rett being a developmental disorder, her tonsils did not develop. Katie has a Class 2 Division 1 occlusion with an anterior open bite. Continuous thumb sucking has caused her occlusion to shift and anterior teeth to flare. Katie has a tongue thrust. Upon my clinical assessment, I noted that Katie has all primary dentition with the exception of each lateral incisor. Katie has not lost a tooth yet. No periodontal assessment was complete due to her age and dentition status. Katie has not had orthodontic therapy or has removable appliances. Katie does not tolerate radiographs well. Due to her cooperation and help from mom, we only take bite wings once a year. Dental caries are evident on the interproximal surfaces of I, J, K, and L. Dr. Smiley has reviewed these areas and confirmed cavitation. Upon completion of the nutritional analysis and dietary assessment, I concluded that Katie has a severe digestive problem leading to diarrhea and gastroesophageal reflux. Dysphagia also makes it hard for her to consume foods with high values of nutrients. Soft foods are easier for Katie to chew and swallow. She presents with a low intake of iron and protein. While her parents try to incorporate healthy foods, Katie's diet is restricted due to her disorder. Her parents coordinate with her picky palate by implementing fruits, beans, and small portions of meats as much as possible. Like any toddler, it is often a struggle to persuade Katie to consume nutritious foods. Katie is considered a high caries risk patient because she consumes sugary foods frequently, has xerostomia as a side effect to her medication, presents with heavy visible plaque, and has current visual and radiographically evident carious lesions. Katie is also at a high risk for the development and progression of periodontal diseases due to RTT. In addition to her systemic factors, Katie's local factors of heavy plaque and biofilm-induced gingivitis also gives rise to greater disease progressions. The condition of Katie's oral health is faulty. She presented with generalized moderate plaque and mild supragingival calculus around the molars. Her personal hygiene performance was ranked at a 3.5, which is classified as poor. Katie attempts to brush her own teeth, but she performs poorly due to her neuromuscular status. Mom or Dad always helps Katie brush in the mornings, but Katie often falls asleep before brushing at night. Katie receives inadequate brushing with the manual toothbrush once a day and flosses with floss picks 2 to 3 times weekly. Treatment provided was a child prophylaxis, oral hygiene instruction, and nutritional counseling. Katie cooperated during treatment to the best of her ability. I incorporated new techniques to provide individualized, comfortable, and patient-centered treatment by allowing Katie to pick out stickers throughout assessments during the appointment and incorporating all things purple. I had no issues with her parents. They only brought their concerns for their child's health and was eager to improve in preventative measures. Katie was fully aware of her surroundings during the appointment, but she needed constant reminders of her role. She can follow commands well, but her tracking of items and comprehension is delayed. In giving oral hygiene instruction, I suggested the use of an electric toothbrush and presented her parents with its benefits. Electric toothbrushes can provide a more thorough cleaning by reaching difficult areas that are often missed and also helps children who struggle with dexterity. I also recommended that the patient switch to Kids Crest Advanced toothpaste. I reinstated the importance of using floss picks nightly. Katie's diet mainly consists of soft foods that easily stick to her teeth. Without nightly removal of materia alba, which is food debris, bacteria, and dead cells, Katie is at an even greater risk for caries and halitosis. Katie was able to understand my OHI instructions, but her ability to perform adequate home care is lacking. She needs supervision in brushing and flossing, which is why her parents are included in all aspects of treatment. Katie is set on a 4-month recare due to the amount of biofilm present and her special needs. Here is a list of all my resources. October is Rett Syndrome Awareness Month, so I'm grateful for the timing and sharing this presentation with you all. Thank you.